Good afternoon, everybody. I have a pleasure extending an invitation for all of you for this afternoon monthly meeting. In the absence of our chairman, Dr. Satish, I request Professor J. Srinivasan to officially inaugurate this conference and welcome all. As you know, J. Srinivasan is the founder of this institute, and it is the scientific program bachelor's in IIT Chennai. Then New York is his MS, and Stanford it is PhD, and he was there in NASA and all the things as a scientist. And he came down here and atmospheric science, oceanic sciences, climate change. With the help of the Divecha people, he built this program as the first chairman of that one, and he continues to be the special professor here, and he's a man behind all the scientific activity, you can name it, and he encourages so well, unbelievable, and also stimulates us. Sometimes we interact with certain issues. We'll argue for those things. And he's a man with simplicity, and you can approach him anytime, and he's always a helpful person. In addition to that, he practices what he preaches. Why do I say that is that now the IPCC report says you have to reduce 2 tons of carbon footprint every person per year, so that our temperature will be maintained 1.5 degrees by end of this century. He practices that. Double the amount. Why? He walks 3 kilometers from here to here. We don't have a car. If you don't have a car, you save 2 tons per year. Simplistic. 0.9 tons you can save by that one. In addition, shopping here and there, he goes in walking only. So you can save another 0.8 tons. So nearly 3 times the carbon footprint he saves what we preach. I think these are all the values we can learn from him a great deal. And in addition to that, his uncle is none other than late Nobel laureate Sir C.V. Raman. And I have a great pleasure, sir, to requesting you officially inaugurate this program, and I can welcome the people. Thank you very much, Sir J. Srinivasan.
Thank you, Dr. Paramesh. Welcome you all to this monthly talk that is organized by Dr. Paramesh for the last 3 years now. And we have heard many talks about many diseases in this period. And it's also under ComHAD auspicious. And today we have a different viewpoint, which I think we should have, which is about universal healthcare. Not just about disease, but about general. And I'm very happy that Dr. Paramesh invited Dr. Ravi Narayan to give this talk so that we all get a perspective of not of disease, about health. So I request Dr. Paramesh to introduce the speaker.
I once again extend a hearty welcome for all of you for the scientific program. Universal health coverage for everyone, everywhere is the program. Just to according to the agenda, the introductory remarks on this subject and introduction of the speaker, and also I'm moderating this program. I think the World Health Day is a global campaign that is recognized and supported by the 193 World Health Organizations. Country members celebrated on every 7th of April. This day was created by WHO in the year 1950 with an aim to focus on issues of global healthcare by sharing a simple message that giving healthcare without financial hardship. In 1948, the first World Health Authority, Assembly, was held by WHO, in which the Assembly decided to celebrate World Health Day on every 7th of April with effect from 1950 onwards. World Health Day is an opportunity by the World Health Organization to draw attention to mark the importance of the global health every year. This day is celebrated by numerous countries and non-government organizations dealing with the public health concerns who have coordinate events and showcase their involvement in media coverage such as Global Health Council. The top 5 health issues according to WHO are: number 1, non-communicable diseases, infectious diseases, maternal and child health, and environmental risk, universal health coverage. Each of these issues is critically important, and we need to do everything we can to address these issues so that we can do to help these issues. Well, start by learning more about these issues and sharing what you learn with your friends and family. To talk this important issue, we have a great humanity person. He's a dear friend of mine, Professor Ravi Narayan. His biodata is almost many pages. I just summarized that one important one. Ravi Narayan did his postgraduate MD in All India Institute of Medical Science, New Delhi, and DTPH in London, DIH in UK. He's a community health advisor, Society for Community Health Awareness Research and Action, that is SOCHARA. It is in Bangalore, a community health policy resource group, an architect of the store. He's an archivist, storyteller, and philosopher. He was a faculty at St. John's Medical College for over a decade and an overseas lecturer in London till 1983. He's one of the activator of the WHO theme, Social Determinants of the Health. He started from 2000 to 2015. Rudiger Kresh is also in charge in this one, sir, as you know about it. He is an advisor to British Medical Journal and International Public Health. He was the member of the advisory committee setting up the Rajiv Gandhi Institute of Public Health and Center for Disease Control at the university. We were all the members, advisory committee members during that time. We worked together. Unfortunately, it is not taken up. It's the way what it should have been. Professor Ravi Narayan continues to promote 5 components of public health for all, like equity, gender equality, rights, integrity, and quality. Ladies and gentlemen, it's a great honor for me to welcoming Ravi Narayan. Sir, it's over to you. Thank you very much.
Friends, it's a great pleasure for me to come to Indian Institute of Science again. I've been visiting this since 1974. So it's my, I don't know which 5th or 6th decade. And it has been a great pleasure for me that in each of these decades, I have worked with one department, hopefully exploring as a person with interest in health, some aspect of it. And so I'm very happy now as the 6th decade starts that I make my first contact with the Divecha Center, though I've known Dr. Parameshwar for a long time. Today, what I'm going to tell is, I'm not going to tell you the story, though I'm a storyteller and everybody knows that, that I always not only overshoot the time, but also my stories go on and on. And so I would start by saying, since I see a lot of young faces, which is always makes me very happy, because it's the young, the Gen Next who are going to take on these new ideas and convert some of the new paradigms that we've thought of at the end of years of our own research and our own work that we need to really explore. And I would say today, I'm going to be very purposely provocative, because I think there's been one aspect which for years, 50 years, we haven't still made a breakthrough. And that is understanding health. All over the world, and WHO started from 1948. And as you know, in 1948, when they formed the World Health Organization, they didn't have to define world and they didn't have to define organization, because by that time they were both, they defined health. But till today, when we're on the 75th year of that definition, we're still exploring what health is. And so when I first was requested by Dr. Parameshwara, I wrote a more provocative title, because of late I feel my role is agent provocateur. And that's why I'm called archivist, storyteller, and philosopher in residence. Was called Health for All, what it is not, and who decides. Okay, but it's been changed now to universal health coverage, but I still stick to it. I want to start straight away by sharing a few things, and I hope there will be enough time for some questions. But I would suggest to all of you, if you have sheets of paper, please do write your question down, and we will definitely leave. We are a network called the Society for Community Health Awareness. We run learning programs. We work a lot on this, and we welcome any of you to continue to dialogue, debate, and to work together with us in the years to come. Let me just go. How do we? I'm just by. Oh wait. Yeah. No, it's not. Okay. Sorry. I'm not a tech-friendly person, and so I'm very happy to have brought my younger colleague now, who's come in to digitalize the work of Sochara, Akshay. And usually I like Akshay to be standing here, because if I run into problems, but I think I'll manage this time. Now, let me just start by saying that, wait, it seems to be, I hope it's not moving on its own, or did I do something? Anyway, I want to just say again, just to, what I'm going to try and explore with you all in a provocative way is that today we use lots of words. We use health for all. That is the WHO definition. We're using the word universal health coverage. In earlier years, we used the word primary health care. We want to start a health institute. We are doing health sciences. And I feel what has happened is we have created so many new words, and each of these have different meanings. But we really need to go back and say, are we all talking about health in the same way? Because you could be doing universal health coverage. And the biggest problem, which I find, and which I can say is more or less underlines the whole basis of this, is that till today, 75 years after the definition, health and medicine are treated synonymously. And I'd like to start by saying health is not only medicine. Medicine is part of health, but health is much more. So that's the main topic of what I'm going to try and tell you. It's been a long journey for me. I trained in medicine in 65. Sudhir here from NCBS, we both are from the same institution, St. John's Medical College. Then I did public health. I did preventive and social medicine at All India Institute of Medical Sciences. But over the years, I discovered that I had to move beyond the medical college. And I did that just before I became the head of Department of Community Medicine, to start with a whole group of colleagues who were as maverick and as me, a Department of Community Health. And because we were not based in a university, we called it the Community Health Cell. And for the last, from 1984, when we started it, till 2023, Society for Community Health Awareness trying to understand what is health, and we do it through praxis, not just philosophically. So this personal journey started long out of a medical college. When I thought of community, when I thought of health, of people and of communities. Like this young doctor, I came out with lots of medical skills, but very little community knowledge. Then by quite accident, and this is an accident of lives in many of our cases, 10 million refugees walked across a 1,000-mile border in the beginning of when East Pakistan became Bangladesh. And you won't believe it that Bangalore University, it has never done that again, recognized that if any young doctor, intern, would go and spend 3 months there, it would be treated as public health posting. So I led a whole team from St. George's Medical College, and that 3 months completely changed my life. Because somewhere at the end of 3 months, I felt I had been a health person, not a medical person. I had been trained in medicine, but that 3 months again, my whole life has been trying to explore what I learned from that 3 months of working in health. And therefore, I came back, worked out, and I'm trying to personalize it because I want it to be a journey that all of us can make. Now, let's just go back to the WHO definition and understand what it is first said. Okay, before that, I must say one thing. I've been asked by WHO recently also to write about this interesting connection. I know, we in India nowadays, we fall into this trap of we always knew something better than, but I'm not going that. I'm neither Hindutva nor nationalist in that sort of sense. But it is true that in 1946, 2 years before WHO defined its health, a report came out in India, the Joseph Bore report, which was called Health Survey and Development. And it was a report which said that in 25 years' time since independence, 47 to 72, we would get health for all. So it is true. And now WHO, people have been asking me to write a document saying, we are not saying that Boer committee led to health, but they used words which we are using, and they use health for all. Okay. So let us see. Now, what did Boer committee say? What worries me is that most of you outside of the medical colleges would never have heard of Sir Joseph Bore. It's the biggest, the most voluminous health report of any of the world. There's never been like 3 volumes, 2 volumes of recommendations, 1 volume of recommendations, and 2 volumes of background papers. We've never had a health policy report anywhere in the world that big. And most people have not read it, even in the medical college. They have read the paragraph in Park's textbook and therefore know only that much. Now, I want to just tell you, start by saying, this is what they said. And please remember, we're talking about 1946, 2 years before, 1 year before India became free and 2 years before WHO met. No individual should fail to secure adequate care because of inability to pay. Very clearly, health for all is health for all. Not health for many more, not health for those who can pay, it's health for all. Second, health services should have special emphasis, 1946, on preventive work and environmental hygiene. It should be as close to people with maximum benefits to the community. Active cooperation of the village through health communities. The doctor is a social physician, not just a general physician, and health for all will come by 1971 AD. This is 46. Most of us, even public health people, don't know that. What was also interesting in 46, and I've really studied the board committee, because to me, it's like a foundational document for health, that no permanent improvement of public health can be achieved without the active participation of the people. So community health is not some special paradigm. You can't have health if the community is not involved. So community health has to be there. And what it also says that we must build up spirit of self-help, the community. And in 1946, which later only in 2004, India accepted in NRHM, they said village health committees and voluntary health workers. Today, we have 1 million Ashas who've been given the COVID Warrior Award. And most of you don't know what that's all about anyway. And we'll come to that. So in 46, when WHO wrote its thing, they very clearly said, please remember, physical, mental, and social well-being, and not the absence of disease or infirmity. So without saying health is not medicine, health is not medical disease, health is not disease, WHO is saying health is well-being, physical, mental, and social well-being. And till today, I haven't gone into any audience and started talking about health to find that nobody talks about doctors, nurses, drugs, hospitals, anything. When you start talking about health, we talk about nutrition, we talk about exercise, we talk about environment, because health is really well. It's only when you come into the medical college, because we guys are walking around with our white coat and stethoscope, that we see you all as patients. And for us, our psychology, Pavlovian respect starts only when we find a disease in you. But disease is not what was meant to be a health. So all the health we are talking about should have been before you arrived at the medical college or the teaching hospital. The next one, in 1977, for nearly 20 years after, WHO decided to do a study with UNICEF saying, are there any models in health anywhere in the world which have taken us seriously in some way or the other? And we're not only with this whole corporatized, commodified, private sector, corporate model of healthcare, which is what has taken place all over the world, including NHS. In 1977, again, these are studies that most people are unaware of. You know the Alma Ata Declaration, but the Alma Ata Declaration was not 125 misinformed health ministers who signed a declaration because they thought health was so. It was a study done for 2 years by WHO and UNICEF, studying 7 or 8 systems, 7 countries, where some experiments had taken place, which was going beyond hospital systems. China, Cuba, Tanzania, Venezuela, Nigeria, Yugoslavia, sorry, I was spelling Bangladesh, India, and Niger. And what did they say? They said, if you want health for all, in 1977, before Alma Ata, they said communities should be involved in designing, staffing, and functioning of their own health centers. Primary healthcare workers should be there, and cultural patterns, felt needs, and community development must be part of that understanding of health. Okay. Then the 1978 Alma Ata came, and till today, I find people use the word health for all. But are you, when you think of health for all in your mind, or as a professional, or as a researcher, thinking of medicine for all, a vaccine for all, a drug for all, some sort of testing for all, then that's not health for all. Health for all is much more. I'm not saying it's not, but it's not only, I should be careful. Primary healthcare, health is a, so these are new words that came into the WHO dictionary, and we've all started using it. Health for all, primary healthcare, health is a fundamental human right, equity, which is reaching the unreached, appropriate technology, appropriate to lives of people, not appropriate to the market economy, or appropriate to engineering, intersectoral development, community participation. Okay, so 1948 definition, 1978 quick check. And though Alma Ata Declaration was signed by 125 countries, including India, I think not many health professionals had really become health professionals. Today, many institutions are changing their word to health sciences, to health institutions, but we are basically medical colleges running medical degrees. We have not moved into health. Even St. John's, my own college, has now taken the cue from us. The Department of Community Medicine, which I left and which Prithvi was in charge of later, has become the Department of Community Health. St. John's Medical College has become the St. John's National Academy of Health Sciences. But by and large, they're still stuck in the biomedical model. Now, in 1990s, many of let's try and push these broader ideas, nutrition, sanitation, all these things, all that is part of health. But by 1990s, it was clear to most of us that though everybody had signed health for all, various groups, big pharma, and corporates, and I don't want to make any sort of people as like villains and so on, but they had pushed a more biomedical, corporatized, commodified, technologized model of health at the cost of all these activities. So I'm not one who says that shouldn't have been done, is necessary, but you need to do other things as well. Otherwise, you keep landing up with illnesses and so on, and the medical model takes over. And we justify the medical model. All over the world, cardiology centers are closing down open heart surgery and angiograms because health rules in Scandinavia and others. Here we are starting more because we have a large backlog, and definitely we need to treat with them. But if everybody was following a more important diet, was exercise conscious, there were all sorts of health in all policies, the need for heart disease will go down. We are in a slightly different situation, so I'm not taking any sort of position. So in 1990s, those of us who had moved into the communities and in projects began to find that government expenditure on education was coming down, expenditure on health was going down, and so on. And at that time, we began to understand that there was a new economic policy that was beginning to affect health, and health, it was beginning to affect wars, violence, access to water, and all of those were the things that Alma Ata said we should be doing something about. Now let's just take a little break. So what I'm saying is WHO had a long, but had got caught sometimes in its own medical model. Now, was there any models coming from other places? So I'm just quickly going through a few, just to give an idea that as everything in the world, there are scientists, there are thinkers, there are groups who are practicing. So the first one, which again is very interesting. Sorry, I know I might sound like a nationalist, but I'm not. In 1976, 2 years before Alma Ata, ICMR of all groups looked at, are there any alternative approaches to healthcare in India at micro level even, doesn't matter, it may not be at state level, may not be at district level. And they picked out 14 alternative approaches, including approach that are medical. We were the only medical college in India at that time, which ran India's first health cooperative, adding a health function to a milk cooperative in Kolar. And the second medical officer is sitting there, Dr. Prithvish, who recently retired as professor of community medicine in Ramaya and is an ICMR consultant. But we've all worked since then. But we were just one of the 14 projects that they studied. And in a year or two, they found 14 more. So there are 28 projects, initiators like us, who are called pre-Alma Ata pioneers. Because one of those 28, the Jamkhet project, made it into the whole WHO study. But it is there. And these are the things they said at 1976. Why I keep bringing the dates in? Because we are talking about 30 years later, 40 years later. And academic, completely covered on these issues. Integrating health with development. In 76, they said that. Appropriate technology, appropriate for people's health, people's lives. You can have two vaccines. Covishield and Covaxin is definitely more appropriate for global health than Moderna and Pfizer vaccines. By any sense of imagination, you can make out. Because, okay, what am I doing? Oh, sorry. Okay, so all these, I just go to this. Let's go to Malur. Malur was where I just gave it as an example. This is the most interesting finding I found, and that's what the whole Sochara is based on. Most people don't believe it, but I'd ask you to please read it. If you had to go health for all, you never think of going to ICMR, Indian Council of Medical Research, because they're called Indian Council. They haven't changed it to health research. And yet I always start with this document. In 1981, when India had come back, signed primary health care, Alma Ata, Health for All, they asked the two top research institutions in the country, the Indian Council of Medical Research for Medicine and Health, and Indian Council of Social Science Research. And this is the prescription. How many of you, can you put up your hands, who've seen this document? This is the prescription of the two of the top most research institutions in the country. You can't go higher than that, except the Prime Minister's office now. But otherwise, ICMR, ICSR, how many of you have seen, this is the 1981 Health for All prescription by two of the, how many, can any of you put up your hands? You see. If I tell you about Health for All, WHO, some of you can. If I tell you about McMaster model, Hopkins, Harvard, many can. But our own models, none. What did they say? This was the prescription. It's the last page, of course. They said a whole book, and I want you to read the whole book. First, if you want to improve health for all, you have to tackle poverty, inequality, and spread education. So right to education and right to livelihoods is the first antibiotic for health. Second, organize. Remember, scientists like Professor Ramalinga Swamy, these are all well-known scientists who've never been by mistaken thought of as movements, and political leaders are saying you have to organize the poor and underprivileged to fight for their basic rights. ICMR, ICSR are saying we need right to food, right to water, right to all the rights that we have now. Now we see them as Narmada, Medha Patkar, Aruna Roy. ICMR was saying you don't need Medha Patkars and Aruna Roys. The director of All India Institute of Medical Sciences has to be doing that. The director of PGI Chandigarh should be doing that. The director of Indian Science has to be involved in this. Those are the sorts of things they were saying, but nobody listened to them. move away from the counterproductive Western model, which is, whereas an alternative, and finally provide community health volunteers. The same thing that board committee said in 76, they're repeating in 86. 84, we along, I'm not making a case for us. We started community health cell when we had to go to Karnataka state and register ourselves. We had to define community health. This was our definition. Again, we didn't use the word. Dr. Banerjee started the first department of community health in JNU. Now it's a full-fledged account. They also talked about socio-political, techno-managerial, and so on, SEPC analysis. And look at the words they're using. They're bringing SEPC analysis, that is social, economic, political, cultural analysis of the context in which people fall ill. Socio-epidemiological perspective. What we had used was responsibility. Health is a responsibility, health is a right, and health needs autonomy of people. So each of us were then, this was very interesting. Professor Jeffrey Rose, world famous epidemiologist, whom everybody goes to learn epidemiology from because of his fantastic work on salt and hypertension. He, before he died of cancer, wrote a most famous book called The Strategy of Preventive Medicine. And to me, this is absolutely beautiful. For those of you, we'll send you the PPTs because we don't believe it. It's free software. So we are part of that movement. The primary determinants of disease are economic and social. The world's most famous epidemiologist is saying that the primary determinants of hypertension are economic and social, and therefore medicine and politics cannot and should not be kept apart. And he led the whole movement against the salt industry to reduce salt in our processed foods so that hypertension could be reduced, not to produce more blood pressure. I'm not against that. Please don't misunderstand. It's not and, it's not or so on. Similarly, Dr. Anthia, plastic surgeon, set up Foundation for Research in Community Health. All are people you've never heard of. These are the doyens of public health in India. Professor Anthia, Professor Banerjee, Professor Jeffrey Rose, Dennis Burkitt, and so on. So this is what. Thelma, one of our colleagues, went and did a PhD, and her PhD, which is now very well known, she was the first health policy PhD in the London School. In India, she found that the problem with medicine is we are looking at every problem as a medical and public health problem. But if you want to understand health, you must look at the larger inequitable relationships in society, international problem. And her thesis was, according to the level of analysis, you will come with a solution. So most people who think of medical solutions will think of BCG. This is TB. She took TB as an example. It's a well-known paper. BCG, case finding, domiciliary chemotherapy. If you understand it a little more, you'll start talking about development, welfare, income. Today, we know nutrition is being added thanks to the work of Anurag Bhargava. So each of this was that there was a completely different understanding of health. And for most medical professionals who were fooling themselves that they were health professionals, half of these sciences they didn't know. Sociology, economics, political science, because we all grow up in a milieu in India that you are either a nerdy young person, you become an engineer or doctor, and you don't opt for humanities. And if a very brilliant student opts for humanities in school, parents think he should be taken to NIMHANS because there's something wrong. He wants to history, wants to be anthropology. Mind you, these are all sciences. Okay. Now I leave that. Finally, in 2018, we found Health for All was not going to come by some of us going like this and giving a lecture. So we all got together, and that's a whole, thing which I don't want to go into too much detail, called the People's Health Movement. And if any of you are interested, just Google People's Health Movement and you come across it. Today, we've done a large peer-reviewed multi-country paper on what People's Health Movement and the Global Encyclopedia of Public Health of Health Research by Oxford has published it. So I don't want to go into too much detail of it, but it was the first movement which said health is a social, economic, and political issue and a fundamental human right. And therefore, you must begin to understand it in that way. And therefore, more than diseases and viruses and vaccines, poverty, exploitation, violence, and injustice are at the roots of ill health. Okay. So a group of us began to say, let's go beyond health. Again, I keep repeating, it's not against vaccines, drugs. I come from that whole discipline, but we have to go much further. Now, but let us go to a few points. I won't go there, I think. I want to just present 7 propositions because it's a group of scientists and many of you are young. And if I have done these 7 across to you and I will leave it with you later, I hope. The first, that health is not only medicine. I know I might be repeating myself. Health, and therefore health and universal is not universal medical coverage. We need more holistic approach to health and human development. So nutrition, sanitation, gender equality, all that is important. If you don't have that, what will happen is we'll think of health, women's health as an anemia issue. Women's health is a gender inequality issue. Amen. There's no way to prove that women don't get, anemia because of an overall gender inequality in society. Starting from women eating last in a meal, there are hundreds of, issues why. I'm not saying you don't give iron for them, but if you don't change the gender inequality, anemia will continue to be a problem, is what I'm saying. Now, health for all includes systems beyond medical care. I was so thrilled to find that there's going to be a college here on the Indian Social Science campus, and I hope it will be a health college and a school of public health, not medical college. Therefore, it will work on all the things. That's why I'm thrilled to come to the Center for Environmental Change rather than the Center for whatever, AI and other things like that, because I feel climate change is the best example of what I'm going to say. If I had given a different talk here on climate change, then all these factors, social, economic, cultural, political, ecological, will become like central to it. So this is very health for all that's the second. The third proposition is universal health coverage or health for all is different from health coverage for many more, which is welfare, mission, and health coverage for those who can pay. And the best example is the COVID vaccines. When the COVID vaccines were being prepared, and I must say it's a great tribute to science also, the way scientists, researched and sort of shared information and the number of vaccines that came. If you think of it, a group of scientists, epidemiologists, immunologists all got together, and very early on, there was a whole movement of international scientists. So they said that COVID is an international emergency, and therefore COVID products, both drugs and vaccines, must be public good. So the people who are thinking of access and accessibility and so on must begin to think of how can we make it easily available to all, not related to their ability to pay. But that didn't happen. And one of the reasons COVID took much longer, there are other, of course, epidemiological reasons, is because we commercialized things. And therefore, the people who could pay could get more vaccine, people who couldn't pay could not get vaccine, whereas it had been free. And big rich countries like US, and I was in US, Washington for 4 months during that epidemic, everybody's getting it free in a country like, which is like the home of commercial commodified healthcare. Here, people were paying. And so there are whole issues which I don't want to go into, but I want you to understand health for all has to reach everyone. And if some people can't be given that through their insurance and through their ability, we have to think of other methods by which we do. I know money is needed, but it doesn't have to come from the person. The next one is that you must have people participate. That's the most important. Unfortunately, whenever I go to any place and I talk to them, one of the easiest way I can find out, are you think of what you're doing as medicine or health is very simple. When I talk over the patients, when I talk about the people they're dealing with, are they talking about them as patients, clients, users, beneficiaries? Do they use these 4 words? If they use these 4 words, they're the medical model. If they use the word as active participants and co-creators, then you are. That means they're wanting people to share their experience so that you can help in the improvement of the innovation itself. Very important. All of these might sound philosophic, but had we time, and I'm sure with Akshay's help, we can send you a reading list of peer-reviewed journal articles on every single one of these, which are no longer philosophic, though I might be a philosopher now, presently in mind, but has a lot of data there. The 5th proposition is that HFA needs technological innovation. We're not anti-technology, but we want to go back to appropriate technology relevant to the lives of people. If technology is relevant to the lives of people, it will be health for all, because everybody will want it. Today, what is happening is we are improving technology out of context of the people's lives. And therefore, we are causing some new problems. And we must have socio, cultural, economic, and community appropriateness. I myself have worked on a 15-question way by which anybody, we have had a meeting, I find Ramnath is sitting here, with Celco, the whole lot of young innovators whom we got together, all of them are pushing, somebody's pushing a baby warmer, somebody's pushing things. We said, okay, fine, you're pushing something. Let's just look, is it appropriate to the community? We asked them those 15 questions. We had a workshop, and then they said, oh, this we never thought of, this we never thought of, let's go back to the community. So it was not that their technology was not good, but if you're wanting the technology to be used by the people, you have to make it more appropriate to their lives. And therefore, there's a whole guide. Similarly, it should be plural. And today, we've all read Prime Minister's speech. I don't usually like to quote Man Ki Baat or any of his other speeches, but he did say some things, but he did get some of it wrong, which was he was still thinking of health as medicine. But overall, he said some beautiful things today, which I'll tell you at the end of my talk. Proposition 7 is that we do need hardware. But imagine the whole IT revolution with only hardware and no software. It wouldn't have gone. There is a software in health which is not finance, structure, systems, and technology. It is human resources. It is the most not only utilized, wrongly utilized, and wrongly produced in the country. And social health promotion, health communication. We're talking about telemedicine. We need telehealth. And telehealth, it has to be both ways. People tell the health professionals or health policymakers what are their problems, and we tell them what can they do at their lives. And that is why I don't know how many of you realize that why 1 million Ashas got the COVID warrior. It wasn't politics. WHO was signed to send the money. We are in a country that had produced vaccines, country that's got world famous, professionals. How come the COVID warrior went to 1 million women Ashas? Because today, what little success we've had in India, or a lot of success, it depends on what data you're looking, was because we could reach our people through 1 million voluntary women workers called Ashas, accredited social health activities. All of you must have read about the pink sari women. Nobody could go into a community, neither the police, nor Amit Shah, nor anybody, nor the professionals, nor the person giving the immunization without a pink sari woman walking with them. It happened even in our own center. In fact, we got our health workers of Sochara to wear pink saris and go in because that was so much more easier. But don't say that too much because they were unofficial, but we have trained them in the same way. Now, I just want to end with a few points, which is 5 points, all of which we can refer to some articles. And we hope young minds like you will convert these shifts in the thinking into their small innovations here, but they can. First is the paradigm shift, health to medicine. And I want to go into detail. If you come to our center, go anywhere, you can look it up. We have to move from this very biomedical techno-managerial, not to a different one, but add the social community part of it. The second is SEPC analysis. And this I've done for the Dorabji Tata Center, because it took me a long time to understand scientists here who said, all this is very interesting, Dr. Ravinara. We need all those social factors, economic factors, political factors, anthropological factors, but it is someone else's job. Okay, another group of scientists. So all I wanted to get across was, if you are working on a particular public health challenge, dengue, you might be working on COVID, you must understand the biomedical determinants, which you will, because otherwise you won't be working on it. You will understand the public health challenges. But if you really want to understand the relevance of your work to the country or to the economic or to the situation that you're working in, whichever part of the world, you must understand the socio-economic, cultural, political determinants and context of those people. If you don't understand that, then what you produce may be a nice scientific innovation, but may not be relevant. So I'm not saying that you stop doing this and all become activists, but I'm saying scientists must become multi-sectoral, multidisciplinary, transdisciplinary, because when you come to plurality, okay. And these are things we have worked with Dorabji Tata on: tuberculosis, malaria, diarrhea, disease, acute. And in every one of these the documents, you'll find that there is a symposium report, which is there available in your library. There'll be one such table in that, somewhere in that book, which is the biomedical determinants, the public health determinants, and the SEPC. We were hoping that researchers working in one of these areas would also work. And to me, I have not done one for climate change, but it would be a great one because you could not do climate change without this sort of understanding. Because the larger is what there's glaciers melting, whether all sorts of things are happening, temperatures changing, all that's going to affect. Ultimately, viruses and water and all that's going to come in excess, and those are going to affect. So it depends on where you start, but I think it can be a great place to start and work on. This is also being accepted. I worked with a group of epidemiologists. It took me a long time, but I must say, at least philosophically, in the Southeast Asia region, the epidemiologists from all the Southeast Asia region met, and this book, Regional Report, says the scope and reach of epidemiology, which is an integral part of public health, must include. We're no longer talking about activists, PHM movement, even WHO. The epidemiologists from CMC Vellore, from All India Institute of Medical Sciences, from BRAC Bangladesh, from Mahidol are saying we have to study socio-cultural, economic, ecological, and political determinants of health because they're the keystone for use of evidence. I forgot to take the next paragraph of this report. I'll send it to Dr. Parmesan because it says only then can important changes like climate change be ever tackled. That's the next paragraph. Climate change and financial shutdown were taken as the two major causes of ill health, which need this sort of broad understanding. Communitization is another word. All these are words you Google today, you find them. Unfortunately, they're not being taught in academia, public health. So communitization. I don't know how many of you have heard of this word. Nowadays, I go everywhere say you must communitize what you're doing. You must communitize what you're doing, whatever it is. Have you heard? This is a National Rural Health Mission. Google the word, you'll come to India, National Rural Health Mission. It says that all our programs must be community-led and must be through their empowerment. And this all might sound philosophic, but there are 7 components, and I'm not going to give you a lecture on communitization. Look it up. Village workers, Ashas, Jan Sunwai, Jan Samvad, all these are part of how you communitize. So if you wanted to communitize your research in Indian science, this is what you do. Social vaccine is another new concept. It has come. It's been caught. Manmohan Singh spoke on social vaccine. Modi government has spoken on social vaccine. The only people who are not speaking on social vaccine are the academics, researchers in India who don't speak on social vaccine. Because somewhere in the mind, social vaccine is socialism, and socialism means, you know, communists, Marxists, and so on. I'm talking about social vaccine. And all of us who've written this article are senior professors of public health from 5 different countries. You know, and calling us socialists or Marxists doesn't make sense. We've written it in a health promotion journal, international, the social vaccine. And social vaccine is what we used to handle COVID. When you were going around teaching people just 3 simple things: social distancing, masking, and and hand washing, that was social vaccine, because the vaccine was working at the level of the people, and the people were being resistant to COVID infection. Vaccine is different. I'm talking about even so. So this is very important. Even today, social vaccines are there where you resist social and economic structures. That when you teach people to exercise, you are doing the social vaccine for blood pressure or diabetes or whatever, because you're teaching the society how to immunize itself against that disease. Okay. And this is all well recorded. I've just given you a little sum. Finally is values, which is very important. Values somehow we think are religious, spiritual, ethics. No, we talk about values in public health. In the Rajiv Gandhi University course, we had a value. Right to health is a value. Gender equality is a value, and so on. So all these are very important values, and I feel we need to. I don't want to go. I just want to end with the. All this has come in various ways. I just want to end the challenges ahead. I want to end with this. I usually start with it, and this is what in 1973. I hope 223. So many years later, when I walked into London School, Professor Dennis Burkett, head of the British Medical Research Council, showed us this slide. If you walked into this room, or you walked into another room after having listened to my lecture, and you find a tap open, the wash basin full of water, and it blocked, and all the water leaking, what would you do? Common sensically, not even as a health scientist. How many of you would floor mop with multinational floor swabs as a solution to the problem? How many of you would close the tap or remove the block? Put up your hands. Well, most of you. That is it. That's what I'm trying to say. You're going to be health professionals. As soon as you become medical professionals, you'll be floor mopping as more and more illness. That's why most of us medical professionals in our heart of hearts hope we'll get more patients. We're not really happy with health because it means no patients. But that's just because our mindset has been changed like that. This was the other thing which he said simultaneously. You're all researchers. So I'm going to leave you with this. What type of researcher are you going to be? Is your research looking into microscopes? Is your research looking into molecular biology? Definitely, it's all important. A lot of lovely work NCBS is doing is necessary. I'm nothing against that. But is someone also flying in a balloon? Scientists, researchers, anthropologists, social scientists, and looking at trends in society. Today, just now, I was talking to Dr. Srinivasan, the biggest problem in the country is data. You have no data. What is data? Data gives you a sense of what's happening in the community, and we're not able to get that. Okay, so I'll leave you with that. What I've been trying to get across to you is that there's a new public health coming up, and if you and I can begin to look at some of these concepts and begin to look at it not philosophically, I presented it to you philosophically, and go beyond the medical model to look at these larger issues and feel that you are part of health for all. Every one of you, even if you're not a doctor, and you can get in touch with us. We have a community learning program where any young professional can begin to understand health for all over a Tata sort of fellowship and begin to work in health for all, where you drop in with your specialty. You don't drop into medicine. Okay, thank you.
Any questions, please? One or two questions. And all of you.
Why don't you that? Let them ask any.
Any questions? No questions. Then maybe I have to make some concluding points I have written.
Well, let us just see if there are. There are only two options. No questions can also mean that it went from here and went out there. Very nice speech, sounded nice, following coffee and tea. Or it means I'm really seriously in doubt about and send him a long email. But let us see. I'm sure there must be some new. I mean, even if you don't disagree with me, then I did say health for all is coming. Because there's a whole room full of people who believe what I said. Okay. I have a few people whom we have interacted for a long time, 2, 3 fellow students and all that, but that's just by the way. Yes. Please feel free. I'm not the gospel truth. This is just, journey and so on.
Well, Ravi, thanks for the inspiration. One question I would like to ask you. Well, see, if we look at the primary healthcare system in our country, what it was in 1950 and what it is now over the 75 years, we look at the health expectancy was around 35 years at that time. Now it is about 70 years. Wherever we go, we find primary healthcare centers. Looking at various developments which took place, is it good to believe that whatever health system is there has helped us? What are your comments? The health expectancy has doubled over the last 75 years. In this context, do you think all efforts which have gone, communitization and universal coverage, have not gone so far deeper? In spite of it, with curative services, with vaccines, some developments have taken place. And one of the things we see is double that. People live longer, and we have percentage of people above the age of 60 more. all these efforts have helped. That's my feeling. What are your comments?
Well, I'm not at all I fully agree with you. This is one of the biggest issues, that there has been development. But what I'm saying is what we ascribe as the reason for that is different. Did health of people improve? Health for all. So did water supply improve? Did nutrition improve? Did sanitation improve? Did access improve? Did affordability improve? And was that the reason by which our life expectancy has grown? Or is it because we are producing the world's largest number of doctors? That is the issue. Now, my feeling is that this is a very important research question. And in England, when they did this, whether they studied TB or whether they found that development, when they had the women's movement, development was the best contraceptive. It was not the contraceptive. So I think there's enough evidence all over the world that when you look at broad changes in mortality, and I'm not saying that vaccines and others don't specifically reduce something, but we ascribe too much to the biomedical part of it and not to the larger development. So that is what I'm trying to get at. So I have a feeling this issue, what you have raised is, it's not a question to be rejected as something wrong. The hypothesis is correct. Something is happening in this country to justify, and some things are improving, something. How do we relate that to what is really happening? Now, we also know that mortality will come down, morbidity will not come down. So if you start working at statistics level, there are all sorts of interesting ways by which you have to, and therefore trend analysis becomes very important. It is not so easy here because we collect data in the way my professor of epidemiology taught me. And I'd like to ask you this question. Do you collect data for illumination, or do you collect data to understand something? I mean, what did I say? Sorry, I'm not getting it wrong. Now at 75, if you are a drunk using a lamppost, you could be using data for support. In India, we use data for support, not for illumination. Like a drunkard using a lamppost for support, not for. So we collect data to prove something we want to prove, rather than to collect data to see, could this be, can we be illuminated? Is there some sort of, do you understand? So it's very important that we must improve epidemiology, data collection. And I don't think it's a question of either or. That's the biggest problem. It's not only medicine, it's not only development, but both have contributed. Okay.
Come, Sinu. Sir Narayan, you covered the problem very well. Your question quite apt, sir. We're all talking about from 35 years ago to 73 years now. How is it bad? That one is quite thing, and also certain answer is there. We all know about it. No country can progress with illiteracy, ill health, ill wealth. All of three are interrelated. He connected all the three. You should have good education, propagate this one. And also good health has to be there to work hard, to earn more. Economy increases. All the three is interrelated. He covered it very well. And also while measuring about, he mentioned about heart disease was decreasing significantly when the professor said you reduce the salt. Of course, current recommendation of the National Nutritional Commission is reduce your salt, reduce your sugar, and take 10% less than what you eat so that you can reduce your weight, maintain the health. These are all the current recommendation as of 2019 recommendation, as a matter of fact. Sir, heart disease now, because of air pollution is contributed, has gone up now in younger age. Nearly 49% of the chronic lung diseases, 29% of the lung cancer, 25% of the heart attack in younger age, 24% stroke coming from the air pollution. Somewhere you are talking about it, this is what the environmental issues are coming to the picture, you covered it. This is a fact, as a matter of fact. In addition to that, you mentioned about the respiratory problem. I think I was the president of the respiratory chapter of India. During that time, UNICEF, WHO, Indian Academy of Pediatrics, they said the ERI control program is started, sir. You mentioned respiratory disease control. I think it started in by 2000, 15, we have to reduce, we promised 2/3 the mortality from acute respiratory infection. We are going to reduce educating. For 2 years of presidency, I traveled 52 weeks across the country. Every branch of Indian Academy of Pediatrics, I trained them how to clinically diagnose, which is a serious pneumonia. ASHA workers, they helped us a great deal. So, on the 30th of December 2015, UNICEF said acute respiratory mortality has come down 51%. I promised 70%, but we reduced 51%. So these are all the education and all the things, how is important we are highlighting these things, sir. And also telemedicine has to come there. There's no question about it, to propagate the knowledge and all those things. So what happens? We are the scientist, engineer. Your accuracy, physics and mathematics is 100% accurate. 2 + 2 is 4 for you. Science is a scientist. We are all talking about the science of probability, science of accuracy, science of probability. Working together is not easy. It's very difficult. Somewhere work together for the benefit of the society. With all these 3 points, what he covered very well, we are ever grateful, sir. On behalf of the Divecha Center for Climate Change, a token of appreciation, we like to give a small memento. I want you to accept it. Professor Srinivasan, sir, please hand it over. Now let's have the group photograph. So that's what our chairman was, because it's going to be our bulletin. That bulletin. Please come. Vote of thanks.
Yeah.
Vote of thanks.
Yeah.
Yes. Okay.
On behalf of the Divecha Center for Climate Change, I would like to thank Dr. Ravi Narayan for his presence today, and also to all the attendees for being here. So thank you very much. We are honored to have you, sir.